because your vitamin D level is low. You might suffer from muscle weakness. And as the patient age, they begin to have a risk for
further testing is required and being seen by a urologist, etc. Is necessary. Once you come to see me as a as a patient, or once you come to see a urologist, we might say, well, let's reteach that test. Let's check to see, is that number truly a high number? Because sometimes these are the reasons to cause the numbers to come back down. We don't want to automatically jump into doing tests that can potentially have some problems. Other things, blood tests, urine tests can also help to indicate whether there is a high risk or high suspicion for cancer, not just with the PSA, but with the potential for case score, PSI score, which is blood tests, and urine tests can also give us some information. All of that being said, a biopsy of your prostate needed to obtain tissue specimens of the prostate is necessary to make the diagnosis. I would say that once you have the office, explain them with decision not to do that biopsy, again, the biopsy.
Be participating in that discussion, talking to spouses, grandparents, children is very important in kind of getting over that fear, getting over that concern that I don't want to move forward. And oftentimes I would say that it might not be unreasonable for the spouse to say, yes, we need to do this because I want you to be around for the raising of our children, for seeing the grandchildren around. And so it's not just the men's decision, but oftentimes it's the spouse decision that can help to push for that. So it's incumbent, I think, on everyone to kind of be aware of that so that they can make an important decision about their own health and their family health. So once cancer has been diagnosed, and I'm not going to go too much, I think my main point was trying to say screening for prostate cancer at an early stage, detected early, is one of the most important things. I'm not going to go too much into the treatment options of prostate cancer unless there are questions or people do want me to do so. I'll briefly discuss that here. Number one, not all men who have prostate cancer need to immediately go into having treatment. Sometimes we do find, fortunately, a lower risk cancer, a slower growing cancer that can be monitored rather than being directly treated or immediately treated. So we have what's called active surveillance. Active surveillance is monitoring the cancer with repeated PSA levels, repeat a biopsy, maybe in a year or so. If there isn't any concern for a progression of the cancer, then you can safely monitor and see and delay any of the treatments. The issue with that, however, is that studies have shown that black men are at a higher risk of progressing in their prostate cancer diagnosis while they're on active surveillance. So it's important to just be mindful that on subsequent biopsy, sometimes you might see a higher grade cancer, a higher risk cancer that needs to be treated. But the benefit of the active surveillance is that you don't get the side effects or the toxicities associated with the cancer treatment. Other ways to treat cancer of the prostate is going to be the removal of the prostate versus radiation therapy. Radiation therapy can take form of either external beam therapy or a surgical procedure where radioactive pellets are inserted into the prostate. I was asked kind of to talk briefly about the side effects of radiation therapy. So again, radiation therapy, either external beam or seed placement, or sometimes you combine the two of those modalities together. So you add radiation on top of radiation, and especially in patients who have a higher grade cancer. Now, the external beam therapy is therapy that is often treated over a 35 to 40 week session. I'm sorry, week, I didn't mean that. 35 or 45 days session. So it's usually about a 5 to a 7. Um, Typically, during that time, there are some side effects that develop while you're getting fatigue, tiredness, a lot of irritated urine, frequent emergency urine burning. All of those are very typically those will go away once but it may take several non-surgical. Working with a pelvic floor therapist or a physical therapist, doing your own Kegel exercises can sometimes be helpful. Other times, medications are definitely the mainstay that most urologists will offer to you. Most of the times, primary care doctors should be able to offer it to you as well. But medications to relax the prostate, shrink the prostate, pills that can treat both prostate and erectile dysfunction can be used, and then also medications that can help to calm the bladder down. People who have storage problems of being not being able to hold the urine, frequent urination, urgency to urinate. Sometimes these medications can calm those down also. A year. Those are going to be foods that are not going to be very healthy for us. They're going to contain lots of preservatives that are going to be bad for us. So the more that we eat them, the more we're exposing ourselves to those preservatives that can then certainly cause cancer. So considering foods that are very brightly colored, lots of different colored, bright red colors, dark green leafy vegetables. Those are going to be foods that can be very helpful in terms of improving your prostate health, but also your health in general. A lot of these contain what we would call antioxidants, which are chemicals that can help to eat up bad radicals in the body that can then cause cancer. As far as vitamins are concerned, I think trying to get your vitamins through a very varied diet is going to be much more important than trying to take multivitamins or a variety of different vitamins. So if you're adhering to a good diet that has a variety of different fruits and vegetables to it, you're going to be doing a lot better by getting all of the vitamins that are out there, in addition to the fibers, proteins that you can get from them as well. I'm going to stop there. One thing that two more things. Good resources for men with their urologic health concerns. Is one website called urologyhealth.org. That's urologyhealth.org. It's a trustworthy website created by the American Urologic Association, American Urologic Association. So it does have very good information about the common urologic issues that people might be experiencing. And this both entails men and women type of issues. As specific for the prostate cancer, another resource would be the Prostate Cancer Foundation. I mentioned that a little bit earlier, and that would be pcf.org. I think that would be PCF, prostatecancerfoundation.org, and that can provide useful information about prostate cancer as well. So I'm going to take the opportunity to thank everyone for listening to me. I know that I've droned on and on and on about lots of things, but I hope that this was a very helpful talk.
Thank you so much, Doctor. I know that we have a couple of questions, but I think I know we just want to use, if you don't mind, like question. Okay, so we have like 4 minutes. One of the things I put down is that for women, do you have any, for urology issues, do you have anything you can tell?
Yes, I did. So I did focus more on men, and I do apologize for that. The main things that I do, that urologists see women for, would be overactive bladder symptoms, urinary frequency, urinary urgency incontinence. That is very common things that people can see. There are urologists who specifically manage those symptoms. General urologists can certainly manage those symptoms very well. Oftentimes, we can try to manage these with medications, whether they are medications called antimuscarinics or beta agonists. They are medications that you would take once daily. They do have many of those side effects associated with them. Sometimes the antimuscarinics can be associated with dry mouth and constipation. And then one of the things that we get worried about with the older classes of medications, the antimuscarinics, are association with dementia. So lots of times these older medications like oxybutynin, tolterodine, those are used quite regularly, and unfortunately they're the most affordable medications, but they are the ones that are higher risk for association with dementia. So we try to steer away from them these days with the newer medications called beta agonists, or Mirabetrip and Gemtesa. But sometimes the cost of those medications can be prohibitive because they are new. They're the newer generations that are out there. I just learned, however, that Mirabetrip has gone generic, so we're hoping that that medication can be more accessible to people as one of the ways to manage those overactive bladders. One other thing that we often deal with is recurring urinary tract infections. Infections of the bladder that are often going to be symptomatic in terms of frequent urination, urgency to urinate, things that I just mentioned. But then there are also going to be symptoms of burning with urination, blood in the urine. And in the older population, we often see that those symptoms that are very typical, common, are not the ones that we might manifest in the older patients. So older patients might have urinary incontinence or more urinary incontinence, and then also mental status changes. So cognitive changes. So it's important that family members or church members, people who are kind of involved with the older community, older population in the community, be mindful that if the older population is behaving abnormally, that could be a sign of an infection. So checking with the primary doctor, or if you're being seen by a urologist, asking for a urine culture, urine analysis to be started on an antibiotic to treat that. Lots of older women are going to be at a higher risk for developing urinary tract infections because of the changes related to the loss of their hormones, postmenopausal changes, and the vaginal tissue can become much more thin. The pH of the vaginal tissue or the vaginal environment changes, and so good bacteria that would often act as defenses to prevent urinary tract infections, they may not be there quite as much. So some of the things that we kind of talk to people about would be potentially restoring locally a vaginal estrogen cream, a small dose of a low concentration of vaginal estrogen that can help to restore that environment so that the good bacteria can be housed there. The thickness of the tissue can be a little bit more defensive from preventing the urine from the infections from getting in. Other things that we can consider doing would be cranberry supplements. There's not a whole lot of research out there that's saying that it would absolutely work, but I don't think that there's any harm in using cranberry supplements to try to prevent infections from occurring. I would say that those are the two main things that I often see women, females for. Across the board, kidney stones for both men and women, of course, but your overactive bladder symptoms, urinary incontinence, recurring urinary tract infections are things that I do recommend being sought after and talking to your doctors about those potential therapies that I've mentioned.
Thank you so much. So the final question, because of our time, is that we know that this prostrate problem is for men. A lot of time in a relationship, how does the women generally respond? Especially what are some of the common fears that the spouses bring? In terms of, if you can address that way.
So I think that's an interesting question, and maybe one that I'm not the most prepared to answer. The reason for that is oftentimes when I see patients for their prostate cancer treatment, I see them at the front end with their spouses so that we can make the decision as to how we're going to move forward. A lot of times that discussion is certainly one that's very sensitive because I did not mention this earlier, but one of the things that can occur as a result of treatment for prostate cancer is erectile dysfunction. And I think that certainly affects both the men and the women of the relationship. And that's a very personal discussion that one has with the patient and their family members. A lot of times men might say they don't want to have this done. They don't want their prostate cancer treated, or they don't want the treatment of removal of the prostate for fear that they're going to have complications related to their erections. And that affects both parties, of course, right? That affects both the men and the women. I think it's a little bit hard for me to answer how it affects the female as much, because more often than not, after that first discussion that I have with patients and their family members about moving forward with their treatment, more often than not, subsequent visits don't actually include their spouses. So they don't necessarily talk. We talk about the husband's issue, and I think that's a good point that you bring up. It might be something to tell patients to bring their spouses with them so that I can get a better sense of how both parties are being affected by this condition and by the treatment. And so I think that might be something that I can consider changing in my practice. Whether men actually will adhere to that, that's a different story. But I can say, please consider bringing your spouse, because we certainly need to be thinking about both parties in this. One other thing that I would say is there, after the prostate is removed, there can also be urinary incontinence. And that urinary incontinence can also be experienced during sexual intercourse. So men, the musculature and the mechanism to be able to hold the urine in, whether it's during sex or whether it's during regular daily activities, that has been compromised from the surgery. And so leakage of urine is quite common, and leakage with sexual intercourse can be more common because the rhythmic contraction of the muscles to be able to, at climax, can then lead to the opening up of these muscles, which would normally be where semen and fluid would be ejaculated. And so when that musculature is opened, if there is urine in the bladder, urine can leak out during sex. And so, but during the act of sex, there is no real harm that would be incurred by women if urine were to leak inside the vaginal tissue during intercourse. There would be not necessarily any harm, but there can be some psychological, emotional distress that people can experience as a result of that condition.
So I want to just say thank you so much, Doctor. You have really touched a lot of things, opened our eyes. And if there's anything I just want to say is that men, like he said, they are very secretive. They won't talk. But women, we have to be, especially in African descent, our men are very proud. They don't talk. So you have to look out for your men. You have to be proactive. I think I was the one that made my husband go and have physical when I first married him. That I was just after him. It's like, I'm fine. I'm like, you are a certain age, you need to see doctor. So let's please be there for them. Let's be advocating for our husband. Do not let them go to the doctor by themselves. Be part of that treatment. Stuff that you see that they don't want to talk about, talk about it to your doctor, because you are saving his life and you are saving your own life too. We want to appreciate you. So he's going to stick around for a while to answer questions. So this is our time of hello time for 5 minutes before we bring Dr. Fitzpatrick up. So you can rise up and say hello and say hi to everybody. All right. Thank you for the hello time. All right. Everybody, let's have our seat as we go to the next one. Let's have our seat. Remember, change comes from knowledge. There is no transformation without information. So the reason for this healthcare is to help us to live a better life, enjoy our life, and live longer. So that's what this is all about. And we want to thank Dr. Kusikabi. We want to thank Dr. Ajayi, Dr. Laomi, who has given us, the talk of medication, the side effect of medication. Some of the stuff that the doctor is talking about could come from, if you take some medicine with alcohol, you can damage your kidney, you can have a host of problems. The other part of our life that is common that I see more on my floor, and the doctor I'm bringing up, is the problem of intestinal problem, stomach problem. Having like this ulcer kind of burning, diarrhea for no reason, cramping for no reason. Like I said, Africans are noted to self-treat. And some of the medicine we take, they are very toxic to our system. Dr. Fitzpatrick, I met him at Mercy. And I've been at Mercy for over 20-something years. I've been working with him. I've seen him take complex cases. I remember we have a patient that was in our floor, his patient, for over a year. That yet, the woman came out strong and healthy and live. I mean, people refer people all over. So he's here to share ideas with us. He's here to help us learn. And really, I really want to appreciate these doctors. They are really busy in their practice. He just came back from a mission trip. Actually, when I was trying to do the flyer, I have to call him where he is outside the country to say, please, can I put your picture in the flyer to let you know how busy. And he came back last week. So Monday he saw me. He's like, oh, Ronki, what am I doing again? So I really want to appreciate Dr. Fitzpatrick for coming. And he's going to give us lecture. Thank you, sir.
Thank you very much. Thanks to all of you. Thanks to Ronki. Thank you for all the people that work to organize this. I think this is really a great idea. It's really a privilege to be here. One disclaimer, I do work at Mercy, Dr. Kusikabi. I am not here to push Mercy. I'm not here to push any particular brand of medicine. I'm not here to push, Walmart or versus Walgreens versus anybody. I don't have any agenda here. I'm just trying to give you some knowledge. So if it seems like I'm trying to push something, please stop me, because I'm not. I'm just here to try to teach you a little bit. One of the problems we have is there are many, many different things that can happen in the GI tract. It takes 7 years to be a surgeon. There are hundreds of things that can go wrong in the abdomen. But what I'd like to do is sort of focus today on 6 things that happen fairly commonly. They are hemorrhoids, gallbladder disease, hernias, ulcer disease and gastritis, colon cancer, and diverticulitis. There are things that affect black people, white people, men, women, across the board. Dr. Kusikabi talked mainly, obviously, about prostate issues with men. Most of what I'm talking about today crosses both sexes, some affecting one sex more than the other, and we'll talk about that. But really, it pertains to almost everybody. In fact, some of the things, particularly hernias, can pertain to children as well. I'd like to talk maybe about 5 or 10 minutes about each of them, and then, as Dr. Kusikabi did at the end, try to entertain some questions. Okay? If I say something that's confusing, please, somebody, put your hand up. Let me clarify it at the time so we know we don't get confused. So first of all, hemorrhoids. What are hemorrhoids? Well, first of all, almost every living human being has hemorrhoids at some point in their life. For every woman that's had a child, I guarantee you, you know about hemorrhoids. What hemorrhoids is loose tissue from right down at the bottom of our rectum, just above our anus where our stool comes out. And that tissue, that mucosal tissue drops through. Hemorrhoids can present in many different ways. They can present with blood on the toilet paper. They can present by just feeling something coming out of your bottom. It can be an itchy feeling. It can be that when you wipe yourself and clean yourself up after a bowel movement, you just don't feel real clean. You feel itchy. It's not pleasant. Well, the good news for most people is hemorrhoids usually do not need surgery. The vast majority of hemorrhoid problems can be treated medically. As lots of you women know, you had bad hemorrhoids after your babies were born. Sort of things get better with time. But it's important to know that we can do some things both to help us make hemorrhoid symptoms better, as well as not cause them to get bad again. In general, remember that anything that we do that makes us push hard to pass our bowels is bad for hemorrhoids. Getting real constipated, having big bulky stools, going 3 or 4 days between bowel movements, and then we have to sit there and concentrate and push. That's the worst possible thing we can do for hemorrhoids. The best thing for hemorrhoids is to try to keep your bowels fairly loose. We don't want you to be messing yourselves. We don't want you to have to wear a pad in your underwear, but we would like to get to the point where you have a fairly soft, fairly easy bowel movement every day or two. People have all different bowel habits. Some people poop every day and they're very happy with it and it works well for them. Others only go to the bathroom every 2 or 3 days and they're also very healthy. More than how often you go, it's a point of how big and bulky is your bowel movement, and are you able to get it out without pushing? In general, if you're worried about your bowels, the best thing to do is, much as Dr. Kusakabe was talking about keeping a healthy diet, we didn't rehearse this, good healthy diet, fruits, vegetables, and the other thing is plenty of fluids. People don't realize how much fluid in the GI tract helps keep your bowels fairly loose. If you get real dehydrated and have big bulky stools, that's a problem for you. Some people actually need to use some stool softeners. Probably the simplest one is called Docusate or Colase. Taking it once or twice a day can be very beneficial. If your hemorrhoids do start to flare up, there's almost nothing that can happen with your bottom that a nice warm tub bath doesn't help. Sitting down in a nice warm tub of water, it's hard to imagine on a day when it's going to be 90 or 100 degrees, but getting yourself down in a nice warm tub of water will help relax that area. It'll cut down on the inflammation. It'll also make things feel better. Sometimes even just using things like Tux pads or little baby wipes that you would use on your baby to wipe around the bottom can be very helpful in terms of that itching and stinging that goes around with hemorrhoids. It's very reasonable if you think something's wrong to get your hemorrhoids looked at. They can be looked at, GYN doctors can look at them, obviously surgeons can, GI doctors, gastroenterologists can, obviously we as surgeons can. Lots of different people can help you with their hemorrhoids. So if they're problematic, please ask somebody to take a look at them. The other thing to know about hemorrhoids, though, is one of the symptoms of hemorrhoids may be bleeding. You may see blood on your toilet paper, or you may see a little bit of blood on your bowels. Most of the time, that is going to be from hemorrhoids. But the other problem that we're going to talk about later is colon cancer. So if you see blood on your toilet paper, or blood in your bowels, or blood in the bowl, and it persists, please don't just tell yourselves this is hemorrhoids. You need to see a doctor about it, okay? So a little bit of blood once in a while, not a big deal. We'll talk more about colon cancer later, but persistent blood is something that needs to be looked at. So again, eat healthy. The other things that get people in trouble with hemorrhoids are a sedentary lifestyle. It's amazing how much walking, physical activity, not just a healthy diet, but a healthy lifestyle. Walking, activity really makes a big difference in terms of regulating your bowels. The biggest problem, or the medicine that we take, as Dr. Kusakabe talked about, some medicines can get us in trouble, are opiates and pain medicines. They can be very constipating. So if you are going to have an operation, and if you're going to need to use opiates, if you are prone to getting constipated, that's a setup for your hemorrhoids getting worse. So if you're going to do that, let the doctor know we may need to get you on medicines like Miralax or something like milk of magnesia. Those opioids can really be a problem for people with hemorrhoids, which doesn't mean you can't take them. It's just we've got to pay attention to your bowels while you're doing that. Hemorrhoids, very common, affect women much more commonly than men because of the process of child's birth, but certainly affects both men and women. Any questions about hemorrhoids while we're there? Maybe it's easier just to handle it at the same time. Yes. They can. You cannot cure hemorrhoids. You can make surgery for the right reason for hemorrhoids is a good thing. If they're really falling out or they're continuing to bleed, or if you've got clots related to your hemorrhoids, surgery may really improve your lifestyle. That's really why we do surgery for hemorrhoids. But we can't fix you so that you will never get hemorrhoids again. If we operate on 1 or 2 hemorrhoids and you still get real constipated, you can develop more hemorrhoidal issues. So that's why, when we talk about the gallbladder, once the gallbladder is gone, that's the end of it. Hemorrhoids are not a curable event. They're a manageable event. And as I said, most hemorrhoid disease can be modified, with your lifestyle and keeping your bowels regular, good dietary habits, and exercise. Can you push it back? You can push it back. And I think any woman that's had a baby knows that, things fall out. Things fall out along with the baby. You push it back. As your rectum contracts back down, it keeps those hemorrhoids back up inside. If you get real constipated and have to bear down and push real hard, you may push them out again. But yes, pushing hemorrhoids back, especially if you do it in the setting of getting a warm tub bath to relax everything and relax the muscles, pushing them back, there's no harm done with that. It's actually a good thing to do. Hemorrhoids. We'll move around to your gallbladder. Most common operation done in the abdomen is taking out gallbladders. Now, almost all gallbladder problems are related to gallstones. Our gallbladder is an organ that sits up underneath our right rib cage, and we form gallstones for various reasons. Tens of millions of people in America alone, as well as all over the world, have gallstones. Just because you have gallstones, you do not need your gallbladder out. There are millions of people with gallstones that are not giving them trouble. It's completely fine to leave that alone. People have a CAT scan or an ultrasound looking for something else, and the doctor says, "Oh, did you know you have gallstones?" That's fine. If they're not causing trouble, leave them be, because the gallbladder really does function for us. It helps to digest our food. But lots of people start to get gallbladder symptoms. Now, when we talk about gallbladder disease, about 60 or 70% of gallbladder disease does occur in women. But men can certainly get it as well. And unfortunately, when men get it, it's usually a little bit more severe than it is in women, but it's much more common in women. The other group here, particularly, please don't take this as a racial thing, the other group that's really at very high risk for gallstones are people with true sickle cell disease. Everyone with true sickle cell disease will develop gallstones usually by their teenage years. And almost all of those people will actually have their gallbladder out by the time that they're 20. So that's a group that's very, very specialized. Again, fortunately, not a lot of that. But everybody with sickle cell will have gallbladder disease. It's almost guaranteed. What gallbladder disease usually presents with is people describe a gripping, a squeezing, a cramping pain. It starts just underneath their breastbone or just underneath their right rib cage. and it feels like it goes through them from front to back. People often talk, it feels like it goes to their shoulder blade or to the right kidney. It usually follows eating, shortly after eating, within about 15 to 30 minutes of eating, and it usually lasts for 2 or 3 hours. And it's often precipitated by greasy, fried, fatty foods, foods that are rich in dairy products. If that happens and you start to notice that, sometimes what people do is they modify their diet. They stop eating fried cheeseburgers, they bake their chicken or they bake their fish. They don't, and that'll help for a while. The trouble with the gallbladder, once the gallbladder starts to act up, it's going to act up again. Generally, it's very rare. It's not like a cold that goes away and you don't get it again. Once the gallbladder starts to act up, you don't know if it's going to happen another day, a week, a month, a year, but it will act up again. And when it starts to be more frequent, it really does need to get dealt with. Now, if you think you have these symptoms, you should mention them to your physician. And it's fairly easy to diagnose. We get a gallbladder ultrasound, an ultrasound test. And if you've got typical symptoms of gallbladder disease and you have gallstones, then almost all the time, that's all you need. You don't need further fancy workup, that sort of thing. At that point, the decision is yours. Do I put up with these problems? By then, after you've had it 2 or 3 times, most people don't. Or do I get my gallbladder out? Unfortunately, there's not much to be done with the gallbladder other than you either put up with it or you get it out. And unfortunately, once your gallbladder starts to act up, it really should be removed. And the best thing to do is you're in control of it. You can speak with the doctor and you get it taken out under your circumstances at a time that's good for you, when it doesn't impact your job or family or lifestyle. You do it at the best time in choosing for you. Most of the time, gallbladders can be taken out laparoscopically, which is still an operation, but done through 4 small incisions, and usually within about 10 days or 2 weeks, people are back to normal there. Gallbladder is the most frequent problem that people have operations for in their abdomen. Any questions there? Yeah. Well, what the gallbladder does is it actually is a little reservoir that stores a digestive enzyme called bile. And it stores it there, and then when we eat, it's supposed to squeeze that out so that it goes down and mixes with the food in the intestine to help digest it. And it really does have a function, and it really does have a purpose. Once you take the gallbladder out, that same enzyme, that same chemical still goes down and mixes with your food. So it's not that it's not there anymore. It just drips there on a constant basis. So it's not that you deprive your body of something that it needs. That chemical is just delivered to your intestine on a different basis than if your gallbladder works. That's why, since it does have a purpose, we don't automatically say take it out. It really does do something for us, but we know that once our gallbladder starts to act up and give us symptoms, it's just going to persist and it's going to get worse. So that's why we usually recommend that once it starts to act up and you start to have symptoms, it really is best to get it evaluated. Oftentimes, you mention it to your family doctor, your nurse practitioner, or maybe even your GYN doctor, and they recognize the symptoms and they would get an ultrasound. And if you have gallstones, then you would move forward to get it evaluated from there. Oh. Hold it here. Okay, thank you. Next thing that happens a lot are ulcers and gastritis. Similar to gallbladder pain, ulcers and gastritis gives you epigastric burning. It feels like something's burning right between your rib cage, and oftentimes it goes through to the back. Oftentimes it hurts you more when you've not eaten. A lot of people feel better after they eat because the food buffers the acid in your stomach. Ulcer disease can occur in men or women. It's more common in men. And risk factors for ulcer disease are smoking, drinking, using lots of aspirin, using lots of non-steroidal medicines like a lot of Motrin or a lot of ibuprofen, a lot of naproxen, things like that, or if you're on medicine called steroids. A lot of times people come in with symptoms of ulcer disease, and the first response from your healthcare person, which is appropriate, it's fine, is they get you something to cut down on your stomach acid. Usually it's a medicine called a PPI. You know it is things like omeprazole, Prilosec, Acifex, medicines like that. And oftentimes, if you're worried about something, if you've hurt yourself and have been taking a lot of ibuprofen, those medicines can help you a great deal. And maybe that the whole process goes away within a few weeks. If you can cut down on your medicine use, cut down on your drinking, obviously we should cut down our smoking anyway. But if we can change both lifestyle and using medicine, ulcers may often be treated just with medicine and they can be absolutely curable. Unfortunately, if you go back to those same things that caused them before, you continue to smoke, you continue to drink, you continue to use a lot of medicines like, again, ibuprofen or aspirin, ulcers can become a long-term problem. Almost all ulcer disease can be treated with medicine. It really is very well treated with medicine. But if it really does persist, there are operations to stop it. 30, 40 years ago, we used to operate on most people with ulcer disease. Today, the medicines are so good that we rarely have to do anything about your ulcer disease. The one question that we get into is if you keep having pain in your epigastrium and it does not get better, or it gets better to a point and then it comes back, instead of just treating it presumptively, instead of just giving you some Prilosec or Nexium or omeprazole, you may actually need a test, and that test would be what's called an upper endoscopy or an EGD. And that's done by a gastroenterologist where they look down through your mouth, through your esophagus, and into your stomach to see and make sure it really is an ulcer that we're dealing with. We don't want to keep treating you thinking that it's an ulcer when it's really something different. So if you keep having those problems and either it doesn't respond to the treatment that you usually get, or if it keeps coming back, then rather than just renewing the medicine, we need to do something more aggressive about making sure we don't have the right, that we do have the right diagnosis. Most people, and Dr. Kusakabe described going up through a man's penis to look in his bladder. I saw everybody doing this. People are a little more accepting of having a scope put down through their mouth, so I didn't see everybody get quite so squeamish when I talked about that. So ulcer disease, questions about that? Yes. Right. Very good question. So first of all, let me be really clear about something. Very good point. Thanks for bringing it up. If you've got heart disease or you've got vascular disease or you've got diabetes and your doctor told you it's important to take a baby aspirin, please keep doing that. Baby aspirin is a smaller dose. It is not as likely to stimulate ulcer disease. So please keep taking that. When I say people that use a lot of ulcer disease, it's people that take lots of full-strength aspirin around the clock. So generally, the reason why we talk about low-dose baby aspirin for heart disease and vascular diseases, it's our way of trying to say, yes, let's get the benefit of the aspirin, but not run the risk of upsetting our stomach. Do you follow? So that's a good question. So if somebody's put you on aspirin for heart disease or vascular disease, please don't go home and say, that guy Fitzpatrick said I shouldn't do that. Because that aspirin may be what's keeping you from getting a stroke, or that may be what's keeping you from getting a heart attack. So that may be very important. It's a very good question. Yes, ma'am.
Okay, so you did mention the pains where
Generally, ulcer disease occurs above your belly button, generally up here. Lower abdominal pain, pelvic pain, can come from a whole series of things. Particularly for you and the ladies in the room, pelvic pain is always a much more difficult issue. It could be from the GI tract. It could be cramps in your colon. It could be diverticular disease that we're going to talk about. Could even be early appendicitis. Or it may be that whole spectrum of GYN disease. And unfortunately, one of the problems for women in this room, women of color, is they have a much higher incidence of both fibroids of the uterus as well as endometriosis. So, and which are, that's not my specialty, we're not going to get into that today, but they are both fairly common and very problematic diseases. So lower abdominal pain often means you need a workup both by seeing, say, a gastroenterologist looking to see if it's a gastrointestinal issue, but you also need to see your gynecologist to make sure it's not a GYN issue. This gets to be a real problem as we try to sort these things out. Yes, sir?
Yes, my question is in low back pain, since you're talking about the post-program, does this lead to low back pain?
No. The pain that you feel with ulcer is usually mid-back or higher. If it's down here, it's usually true back pain. Or the other confusing thing for women with bad fibroids and endometriosis, they may perceive their pain as back pain there. Yeah. Yes, sir?
My question is it doctor give you medication to bring down your acid level and maybe combine it with catechate or something?
Yes.
Yeah. How long can someone be taking it without result that tells you something else?
Well, as I got to before, most ulcer disease or gastritis will go away. So what most people would do is put you on that for, pick it 6 weeks, 8 weeks, 4 weeks, whatever, and you follow up with them. The important point is if that pain does not go away, or if that pain goes away and then when you stop the medicine, it comes back, then it's not enough to simply say, okay, let's keep putting you on that medicine. Then you need usually an endoscopy. You need something to look down there just to make sure we've really got the diagnosis right. And again, that test is called an upper endoscopy. There are other things that can mimic ulcer disease. Ulcer disease is very common, but you can get things like stomach cancer and other things that can be confusing. So that's why if it doesn't go away and run a typical course, we don't just shrug about it. We have to do further testing to see what's going on. Yes, sir?
Can someone who skips meal, especially like breakfast, sometimes even lunch, be prone to ulcer?
Well, it really doesn't so much cause ulcers. Food helps to buffer our acid. So there are some people that do get some indigestion and low-grade burning, and when they eat, it goes away. Because what's happening is the food is absorbing the acid. And if that happens, then that's okay. For example, if you eat your 3 meals a day and feel okay and don't have problems with it, then it doesn't necessarily need to be treated because your eating is absorbing that acid as it should. If you get to the point where your regular meals aren't doing it, then it may need treatment. Okay. Yes, ma'am. Well, good question as well. Foods that may be associated with ulcer disease, in addition to lifestyle things like drinking and smoking and that. Foods that are very, very spicy, things that use the real hot peppers, things that have a lot of acid in them. And the two most common ones are heavy tomato sauces or citrus things, lemon, lime, orange juices. They have a lot of acid as well. So if the problem is your stomach's making acid, we're trying to cut down on that, and then we're giving you more acid, it's a little bit counterproductive. So there are things you may want to be careful of. Yes? this, on the rear end you're talking about. Hemorrhoids are very common, and that's actually where some of the tissue from up inside your rectum falls out. A fistula is actually, imagine a little straw or a little cave, if you will, that runs from inside your rectum out onto the skin down around your bottom. And a fistula usually will have some kind of little bit of kind of like stooly drainage, little bit of pussy drainage, and generally a fistula may have more pain. A fistula is usually pretty easy, not for you to diagnose, but for a doctor to diagnose. Generally, you can see it. You obviously can't get your head down there to see what's going on, but you know, if somebody gets their head down there to examine you, it's usually pretty easy to make the diagnosis. And a fistula may often need a minor surgery procedure to make it better. Hemorrhoids often don't, but a fistula is a different issue that may require surgery. Yes, sir.
So, back in Africa, one of the words that we hear very much is pile.
Piles and hemorrhoids, same thing.
Like the same thing.
Yes, sir.
So, but like back home, maybe it's because of the treatment available. Sometimes it could be so discomforting. Many of them can't sit down
Yes.
until they have to do like a surgical procedure.
So hemorrhoids, as we said, if you manage your hemorrhoids, most of the time they don't need surgery. If hemorrhoids become what we call thrombosed, in other words, if they come out and the blood in them clots, it's not a dangerous blood clot like some blood clots that are going to hurt you, but it can cause terrible pain. And in that case, you may need an urgent surgery to get rid of those hemorrhoids. So that's like one strange manifestation of hemorrhoidal disease. That's like the far end of hemorrhoidal disease that can get you into trouble. And hopefully we get you before you get to that point.
Okay, final question before so that we can go to the next topic. Yes.
Uh-huh. Okay. All right. Okay. Oh, yes, ma'am. Well, as I said earlier, most people have their own habits. You know, a lot of people think you have to poop every day or you're not normal. Some people poop twice a week and they're fine and they don't lose weight, they're fine, they have a healthy lifestyle, they're okay. That's a little bit unusual. Most people will poop every day or two. But if your habits are that you poop 2 or 3 times a week and your lifestyle is good and you don't have problems, and the other thing is you don't have to push down and strain real hard, then you need to use those things we talked about, because whether you know it or not, you're going to get hemorrhoids if you don't already, and they'll start to get, you're tempting fate there. You're tempting fate. And again, it's not as if you're doing something that is real dangerous to you. But if you're having to sit there twice a week and, you know, you take a book with you and you're sitting there pushing, that's not good for you. Okay? Right. Next are hernias. The way you got, some people think that they come in with a hernia and it's something bad. It's got to be cut out. It's got to be something that gets removed because they think that a hernia is like a tumor. A hernia isn't. Let me describe for you what a hernia is. The way God puts this together, there are layers of muscle of our abdominal wall that are woven together, like the outside of a basket or the outside of a barrel. And the idea about that muscle is it's supposed to hold everything inside. So that if this is my abdominal wall, my bowel's in here and the muscle's holding it in. And what a hernia is simply where that muscle splits apart so that instead of having a solid layer with everything on the inside, the muscle splits apart and the intestine or some fat goes through. And most people know a hernia by something sticking out of their abdominal wall. For you ladies that have had children, you probably have what we call an umbilical hernia or a belly button hernia. But remember, there are many different kinds of hernias. The most common one by far is a belly button hernia. There are hernias that occur down in the groin area. Excuse me for touching myself in front of you. But down here, these are generally called inguinal hernias. Or you can get big hernias through places where you've had prior surgery. We call them incisional hernias. The type of hernia that you have is actually important because while generally we think that hernias should be fixed, because, again, if you rip your pants or rip your socks, they're not going to get better on their own. You need to darn them. You need to fix them. Most of the time, hernias need to be repaired. One exception is if you've got a little belly button hernia. There are lots and lots of women who have small umbilical hernias. They got a little outie. It doesn't bother them. They go through life. It doesn't bother them. You can leave them alone. But certainly if it's uncomfortable for you, it should be fixed. The other hernias, particularly the groin hernias and the hernias that occur in wounds, should be repaired because they have a tendency to get very large. And if the bowel comes out into those hernias and gets stuck, then that can turn into an emergency. So if you have a hernia or you think you've got a hernia, it certainly should at least be brought to your doctor's attention, let them look at it. And again, most hernias, except for umbilical hernias, except for belly button hernias, usually will end up getting operated on because, again, they get bigger and more symptomatic as time goes on. It's rarely an emergency, although hernias can turn into an emergency if the bowel comes up in them and gets stuck. Usually it's something that can be done on a planned way. Hernia surgery hurts. It can be done laparoscopically or the old-fashioned way, but it does lay you up for at least 2 or 3 weeks, and it's usually about 6 weeks before you're back to full activity after you have a hernia. But generally, hernias should be repaired. And again, without pushing the repair, if you think you have a hernia, at least point them out to your healthcare provider, whether it's your nurse practitioner or PA or your family doc. Let them take a look at it because, again, hernias can get us into trouble. I'll pause there. Any questions about hernias? Yes. Mm-hmm. So people wear binders, like a big corset, if they've got a hernia. That makes you feel better. You feel like you're getting a hug so it doesn't stick out as far. That doesn't really change anything about the hernia. The hernia is still there. The split in the muscle is still there. It's just, it's not as symptomatic for you. And that's good. If you're not symptomatic, you feel better. But ultimately, that hernia is still probably going to need to be repaired. It should at least get evaluated. Yeah, I'm a surgeon. Everybody says, well, he's a surgeon. He gets paid to operate on people. Of course he's pushing to get it done. It's not so much that, but it should at least get evaluated. It really should. Okay.
What are common symptoms of anemia that people can...
Well, some are completely asymptomatic. Some people just come in with a bulge. Woman comes in, again, an outie. You see a little outie of your belly button. That's an umbilical hernia. Or you see a little bulge on one side of your groin and not the other. Maybe almost no symptoms at all. Most hernias, as they get bigger, people start to get not a bad pain, but they start to get a pulling. They start to get some muscle ache there. Most of the time, hernias feel worse as the day goes on. Towards the end of the day, if you've been working, you've been exercising, you've been on your feet most of the day, Hernias tend to get bigger as the day goes on and get more symptomatic towards the end of the day. When you lie down, you go to bed, generally the hernia goes back in, it feels better, and then the next day sort of the whole process starts again. If you have a hernia that's really painful, or if you have a hernia that's associated with nausea or vomiting or new set of symptoms, then that means that hernia may be stuck, and that needs to get evaluated that day. Again, it's not likely. Hernias generally don't get stuck and get turned into emergencies. But if they really do hurt and it's a different type of pain and you have GI symptoms from your hernia, that needs to get evaluated, because a hernia that's stuck, if the bowel's stuck in it, really can be a danger. Okay. Yes, ma'am. Very good question. So babies get essentially two types of hernias. Little babies, particularly if they're premature children, get inguinal hernias. And that's a function of they're not fully developed yet in mom. Those inguinal hernias, the hernias down in the groin area in babies, should be treated. And most of the pediatricians will know that, and they'll counsel you about that. The other hernias that are also very common in young children are umbilical hernias, belly button hernias. And actually, strangely enough, about 10 to 20% of black children, much more common in black children than white children, have umbilical hernias. The good news about umbilical hernias in little children now, children less than 3 or 4 years old, they are about the only hernia in the human body that may actually fix itself. So usually for children with belly button hernias, we will wait and watch them until they're about 4 or 5 years old. And oftentimes those hernias may actually go away. If they've not gone away by the time the kids are about 4 or 5, we usually will recommend surgery before they start school so they won't be missing time from school later. So umbilical hernias in young children do not necessarily need to be fixed, but the groin hernias do. So what we're moving from now are things that generally are things that we can deal with at the time and place of our choosing or are not particularly dangerous. Two other things now to sort of cross the bridge into things that can really be major health problems. One is colorectal cancer. The leading killer of all cancers in the United States today is still lung cancer. Fortunately, the incidence of lung cancer is going down as people smoke less than they did years and years ago. Colorectal cancer, cancer within the colon or rectum, is the second leading killer of all our colorectal cancers, and the incidence of that is going up. It can affect men and women, white, black, Asian, North American, Mediterraneans. It's a function of our diet. High fat, low fiber, slow transit time diet. It's the environment that we live in. We don't want you to be symptomatic from your colon cancer. Colon cancer is one of the cancers that we are supposed to screen for. And what that means is we don't want to wait for you to have trouble. Our recommendations are everyone should have a screening colonoscopy by the age of 45. If it's completely normal, then you can get another one every 5 or 10 years. If there's a family history of colon cancer in your family, if it's in a young person, then you should have a colonoscopy 10 years before the earliest onset. If your brother got colon cancer when he was 40, you should start getting colonoscopies at age 30. This is something that you need to be invested in. If you need, when you go to your healthcare provider, obviously you know how old you are, you need to tell them, I'm 45 years old, I've not had screening for colon cancer. Women recognize they need their mammograms. That's certainly very important. Colon cancer screening is just as important. So you have to advocate for yourself on that a little bit. We know that if we find colon cancer at an early stage, or there are actually precancerous stages. For example, if you have polyps and we take them out, then colon cancer can be absolutely curable, 100% curable. But obviously, if you let it set up shop and we get to it late, and usually by the time it's symptomatic, it's at a further along stage, then it may not be curable. And colon cancer, not always, the overall cure rate for colon cancer in the United States these days is over 50%. But you don't want to take a 50% chance on a cancer killing you. So again, the idea of getting screened for colorectal cancer is very important. It's one of those cancers that you need to advocate for yourself with your healthcare provider, no matter what type of insurance you ought to have, and even the worst Medicaid type of insurances, all the insurances are supposed to cover cancer screening. So please raise that issue with your healthcare provider. The things that you can do to try to prevent it are, again, eat well. Same things Dr. Kusakabe talked about. Lots of fruits and vegetables, exercise, all of that is helpful. It's not absolutely foolproof. If you've got the genetics that you're going to form a colon cancer, it may not undo that. But we certainly know that people that eat a healthy lifestyle, lower fat, lower meat, have a healthier lifestyle and a lower incidence of getting colon cancer. But again, this is something that you need to be screened for. What comes up, you see it on TV a lot, is Cologuard, the stool test that you mail in. The right answer for getting screened for colorectal cancer is to get a colonoscopy. Now, much like you got a little queasy when they talked about putting a tube up your penis to look at your bladder, a lot of people don't want to have a colonoscopy. It can be uncomfortable. You got to take all this stuff to clean out your bowels before you get it done. And while it's a fairly safe test, it really is pretty safe, it's not completely safe and there can be complications from it. So if you look at TV, you can send off a sample of your stool. And if you are at normal risk, meaning you don't have a real strong family history, you don't have diseases like ulcerative colitis, or you haven't had prior polyps, Cologuard is about 90% as effective as getting a colonoscopy. Now, 90% is pretty good. If you're, somebody told you a 90% chance of winning the lottery, you'd buy it. But again, it's 90% as good as a colonoscopy. So it's certainly better than nothing. And if you're one of these people that says, I'm not going to let anybody stick that scope up there, then a Cologuard is your next best thing. But a colonoscopy is really your best study to make sure you don't have colon cancer. So again, colon cancer is, again, the second leading killer of all cancers in the United States. And by being proactive about it, we can cut down your chance of having, not so much getting colon cancer, but letting it reach a stage where it's not curable. So please advocate for yourselves. As Dr. Kusakabe said, it's often the women that nag. Don't just nag your husbands to do it. You nag for yourselves. Don't forget you need screening too. It really is important. Questions there? Yes, sir. Sorry? Cologuard? It's about 90%. If it's normal and it says you don't have colon cancer, it's about 90 or 92% sure that you don't have it. If you do have colon cancer, it's about 90 to 93% chance that it is going to pick it up. Do you follow? So it's good. And it's certainly much better than nothing. It's much better than just sitting there going, gee, I hope I don't have colon cancer. It's much better than that. But it's not as good as a colonoscopy. Now, the other thing to recognize is if you have a Cologuard and it comes back and it says, wow, we think you have colon cancer, then the next step is you have to have a colonoscopy, because all it does is it tells you something somewhere. They don't know where it is. They have to go in and look for it. Okay. And then finally, the last thing to deal with that also occurs in the colon is there's a disease that you've probably heard of called diverticulitis or diverticular disease. Now, that's also a very common disease. We used to think, going back 30 or 40 years ago, it was an old person's disease. It used to occur in people that were 60, 70, and older. But now we see that it has crept into earlier and earlier populations. Now it's not at all unusual that we see people with diverticular disease in their 20s and 30s. What diverticular disease is where we get weakenings in our colon, usually that part of the colon that's down in our left lower quadrant. And through that, we get little small pockets, almost like a little appendix growing off of the colon. Now, the presence of those little pockets, we say you have diverticular disease or diverticulosis. Now, just because you have diverticular disease or diverticulosis, we don't need to do anything about that. Kind of like gallstones. Millions of people have gallstones. They're not symptomatic. We leave them alone. If you have diverticular disease, it's fine to leave it alone. We may know you have diverticular disease. If you have a colonoscopy, they may see the diverticular disease, or if you have a CT scan, they may see that you have it. But the main way that diverticular disease can get us in trouble is if a little bit of stool gets caught in those little pockets, then it can cause not diverticulosis, but diverticulitis. And you know something's going on there. The most common presentation of diverticulitis is people get a deep, raw, nagging pain in their left lower quadrant. Most of our diverticular disease is down here. You may have a low-grade fever. You may have a low-grade, we'll check your white blood cell count. You may show signs of infection. Your bowels may be a little bit irregular. You may feel like you wish you could pass gas, or you wish you could pass your bowels. Sort of, I feel bound up. If I could just poop, I think I'd feel better. You may be a little bit distended. If that happens, everybody gets a little bit constipated, and then one day they blow things out and they feel better. But if this goes on for a day or two and you're not feeling better, particularly if you're running a fever, you need to come and get that seen. Whether you go to the emergency room or call your family doctor. If you have signs of infection and tenderness in your lower abdomen, particularly on the lower left side, it may be diverticular disease. Now, most diverticular disease can get treated with antibiotics, and it can be much better. We take care of the infection. Sometimes diverticular disease requires surgery. Sometimes diverticular disease can get us very sick, actually to the point where we need emergency operations. Obviously, you would know because you would be feeling much worse. But there's a lot of diverticular disease. It's not just a disease for old people anymore. Don't ever tell your 20 or 30-year-old sister or son, oh, it can't be diverticulitis. We don't get that anymore at that age. Unfortunately, we do. So just be aware that diverticular disease is out there. And we're not going to know you have it generally until you start to get symptomatic from it, unless you've had an x-ray test or a colonoscopy that shows it. So diverticular disease. Again, sort of 6 common problems that gets us in trouble in our abdomen. So questions there? Well, it's not caused by, excuse me. It's not caused by eating peanuts. There are 2 schools of thought. The old school, and I'm old school, because these are little weakenings and little outpouchings in your colon, the old people used to say you should not eat peanuts, corn, or nuts. Because if you ever look at your poop, those things come through you undigested. And the teaching is, then they get to your colon and they get stuck in the diverticula, these little weakenings. And that's what stimulates the infection. So there are, and I have to say, I give that advice to people. But scientifically, people have looked at that and they think that may just be old wives' tales. Do you follow what I mean? So people will tell you if you have diverticular disease, don't eat corn, peanuts, or things with seeds. Now, I mean, we live in Maryland. Everybody eats corn. People like peanuts. It doesn't mean that, if you eat a Snickers bar with peanuts, you're going to drop dead. But if I had bad diverticular disease, I wouldn't eat, 3 ears of corn every day during the summer. I wouldn't eat a pound of peanuts, 2 or 3 times a week. But again, that's my way of looking at it. There's Democrats and Republicans. There are people who say that's sort of proven not to be the case anymore. Did that long answer to a simple question? Okay. Yes, ma'am. Not really, no. They don't. Some people, they feel much better. You kind of blow things out. You feel better. You feel lighter. Feels pretty good. That's not going to prevent diverticular disease. It's certainly not going to prevent colon cancer. Some people do feel better if they do that. The downside of that is we all have lots and lots of bacteria in our colon. And you see these commercials for the gut biome and healthy bacteria in your colon. When we artificially, and anytime we put you on antibiotics as doctors, we run this risk, we may wash out the healthy bacteria, and we don't know what's going to come back and repopulate it. So colon cleansing, a lot of people like it. A lot of people swear by it. A lot of people do it, I don't know, once or twice a year, whatever, because it makes them feel good. In theory, it's not a bad thing. But the thing that you never know, we wash out all your stool, we empty your colon, we don't know what's going to be the dominant bacteria that come back to repopulate it. Do you follow? That's kind of the argument against doing that. It's not really a medical argument, it's sort of a theoretic argument. Do you follow? Okay. Yeah. Well, again, we think that with our unhealthy diet, high fat, lots of meat, not enough fruits and vegetables, we slow the progression of food through our GI tract. Do you ever see pictures of a snake when the snake eats something? And how that, you watch the little mouse go from the front of the snake to the back of the snake? That's really what our colon's doing with food. That's really what the colon's pushing our poop along until we get it out of our bottom. If we get a big, bulky stool, our colon has to squeeze harder to push it along. And we think that increased pressure within the colon is what sets us up for the weakness in the diverticular disease. That's why we think that healthy eating habits, fruits, vegetables, lots of fluids, sort of the same thing we talked about that's good for hemorrhoids, should be good to try to be preventive against diverticular disease. Now, once you have diverticular disease, if you eat well, it's not going to get rid of it. Do you follow? I mean, it's not going to cure diverticular disease. It just may not make it any worse. Yes? Yes. So the answer is yes, two different things. What a polyp is, the inner lining of our bowel. We can get polyps anywhere in the GI tract. But most of the time when we talk about polyps, we talk about them being in the colon or the large intestine. That's what we would see if we did a colonoscopy. And if you imagine, instead of a flat surface, the lining of our colon should be a nice flat surface. But if you look at it and that the lining is raised up, if it looks like a little hill or a little mountain, it's what we refer to as a polyp. Now, what that tells us is that our colon lining is not completely normal. It's trying to make these little growths called polyps. Now, some polyps are not problem. And if you have a polyp, when the person doing the colonoscopy is there, they're going to take it out to analyze it. Some polyps are completely benign. They're not any risk to anybody of any kind. But there are some polyps that may be precursors to cancer. So that you have a colonoscopy and they take out your polyps, you always want to find out from the person that did it what kind of polyps were there, and are they potentially premalignant polyps. If they're the kind of polyps that may lead to colon cancer, then what that means is you can't get Cologuard. You need another colonoscopy. And usually, instead of waiting 5 or 10 years between colonoscopies, we'll probably do it in another 1 to 3 years, just because you've already shown us that your colon is mischievous and we got to keep an eye on it. Again, a diverticulum is a different disease process. It's a little weakening or a little outpouching. Now, in the United States today, there's no reason why you can't get both diseases. People with diverticular disease can also get polyps. So you may get a colonoscopy and they say, well, you got some diverticula in one part of your colon and we took out a polyp somewhere else. They're both fairly common things and they could both occur together. Do that? Okay.
So if you do have a colonoscopy and they do find diverticulitis,
Well, careful.
okay,
Diverticulosis. No, the only reason why I'm being a pain in the ass about it is if you have diverticulitis, you should not have a colonoscopy while you have diverticulitis. You shouldn't get that. But anyway, but I'm sorry, you get your yes.
So, but the doctor, I mean, whoever reviewed it still says come back in 5 years or 10 years. I think you mentioned now there are some cases where it shouldn't be come back in 5 years or 10 years. It should be monitored frequently, like a year or two.
Right.
So in that situation, I mean, knowing what you know now, I mean, so should you at some point call the doctor and say, I just want to get more clarification.
Right. Well, I think if I can rephrase your question, tell me if I'm answering your question. Diverticulosis or diverticular disease does not make you more prone to colon cancer. So if you have diverticular disease, you can be on a regular schedule in terms of screening you for colon cancer. If you have polyps, that tells us that you are at a higher risk and need more frequent screening. Yes, but not diverticular disease. Did that answer your? Okay. Well, again, and this is being really picky. This is real doctor speak. I'm not trying to make it confusing. There are some polyps that are completely fine that don't put you at risk. There are other polyps, we call them adenomatous polyps, that does tell us that you're at increased risk. So it's important not just was it a polyp, but what kind of a polyp, and was it one of, you call it a precancerous polyp. If it's precancerous polyp, you can't wait 10 years, or you shouldn't wait 10 years. Yes, ma'am. I'm sorry? Well, again, I guess the easiest way to put that is everybody's colons work differently. Now, remember that we talked about people pooping normally and that sort of thing. There are things called irritable bowel disease. You hear advertised on TV. There are a lot of people who don't have cancer. They don't have diverticular disease. They just have bowels that don't suit them. They may have episodes where they don't go for several days and they may get diarrhea. We call them functional problems. And while it's not a risk to your health, it drives people crazy because they never know when they're going to poop or they never when they're going to get diarrhea. So irritable bowel things may need a doctor to help you get your bowels regulated. Again, it's not a danger to you. It's more an inconvenience for you in the way that you live your life. Well, it may be partly your diet, it may be partly other medicines that you take, it may be your activity and how much you stimulate your bowel, or it may just be bad luck. You know,
All right. Wow, you know, he's been standing there talking for almost. You are just so good. Thank you so much. Thank you
You're
so
welcome.
much. Now, a couple of things is going to happen.
I'll wait a few minutes.
Great. So let's give him a round of applause. We are so blessed to have these men, you know, they travel, when they go do conference, they speak for 30, 40 minutes. But here they stand up there speaking for an hour and answering questions. We just thank the Lord for that. But there's one program we skip, and we just want to quickly address it, and then we're going to do appreciation for our speaker, and then, you know, we'll do meet and greet before they leave. So it's just going to be 10 minutes. I'm going to bring the financial empowered people because we believe one of the stress, remember all these things we are talking about, one of the major cause of health problem today in this society is stress. In Africa, where I came from, you work Monday to Friday, you have weekend, you do parties. But in America, you work 7 days and you still don't have enough money. So, because the desire is too much. So, we know money is one of the big things. So I'm going to invite the financial team, our CPA, but also our MBA, our financial personnel to come up here and give us their talk quickly. Thank you.
Good afternoon, all. Sorry, ours is coming late. Thank you, doctors. We really appreciate your presentation. Again, my name is Ugo Oso, licensed CPA in Maryland. I'm also a licensed financial advisor, as well as tax expert. I also have my brother here. He will introduce himself briefly.
Yes, my name is Okoyemi Badmus. I'm a financial professional. I use insurance to help people plan for the unexpected. Thank you.
Again, so I would like to quote something, you know, in 2 Kings 4, 1-7, there was that good man who, unfortunately, while he was good, he left debt. And that will segue to what I'm going to talk about in terms of savings. So his wife, he had died. He had 2 sons that was going to give away because of debt. And luckily, you know, and how God does, Elijah came in and saved the situation. But that story tells us that the man didn't save. He didn't save for the rainy day. And that affected his children. In Luke 6:48, it says, he's like a man who built a house and dig it deep. You know, so, and laid the foundation on a rock, and when the flood arose, the stream beat vehemently upon the house and could not shake it, for it was founded on a solid rock. What that means is that that house was built on a solid foundation. They've talked about health so much. One of the things that gives us anxiety, apart from our health, is our finances. Now, anybody can tell you anything about investment, doing good. If you don't have a solid foundation for your finances, you can't achieve any of that. And one of it is debt. According to bankrate.com, 62% of Americans are one paycheck away from losing their home. Most people can't meet an emergency of $1,000 because they don't have any savings account. Most people can't even meet emergency of $500. If I ask a lot of us here, thankfully, there are a lot of us here who are doing very well, you know, in different areas. But from my vantage position, I have seen people who earn upper 6 figures, combined, sometimes even 500,000, talking about bankruptcies because of bad money habits. You know, Yet, I have seen people who earn very little compared to those people and have much more. So what do they do that is different? First, they live within their means. I don't know how many of you know about what they call this, the 28-36 rule. If you have bought a home, one of the things they do, just like the doctors talked about screening, they screen your finances. They'll look at your debt to income ratios to approve what you qualify for. So my recommendation is for everyone to live first like no one else so that you can live like no one else in future. The biggest thing that affects Americans and all of us here is that we spend much more than we earn. If you want to buy a home, the rule should be not more than 28% of your gross income. Not more than 28% of your gross income. So if I take 10,000, 28% is 2,800. If your monthly gross is 10,000, if you had, this is before taxes, because I've not factored in your payroll taxes, your contributions to 401k, your pension, your Medicaid, Social Security, and all that. So once you go beyond such percentages, I know Maryland is very expensive, so we all want big houses and all that. But if you stretch yourself like that, what will happen is that your net income will put you in a very precarious situation. As a financial person, as a CFO in a big state organization, I see people come out excited, oh, I'm making $100,000. That's six-figure income. But when the 2 weeks paychecks comes, it's slightly over $3,000 in 2 weeks. And then, so if you've gone beyond that 28%, that's already affecting you. Then the other rule is 36% of all the other of your expenses, car insurance, car note, car insurance, all of that should not be more than 36% combined. If you stay within this range, it will put you in a better financial position. And then the savings rule. Please, I will encourage everyone, start with a 10% of your net income. If you cannot do 10% of your gross, every paycheck. Make it a point of habit. A time like this requires us to save so much. No one should, like a pregnant woman who becomes pregnant 9 months after you're saying an emergency. Many of us have faced it, I've lived it, so that's why I can talk about it too. I had my kids, I didn't do enough to save when I was supposed to save for their college, and it crept up upon me. Thankfully my daughter is in state, and she got a lot of scholarship, but Maryland is also expensive. It was $30,000 for UMBC. She got almost $20,000, so she saved us that, and we only paid $10,000. But we swore that they will not be part of the statistics suffering in America with student loan issues. My son, on the other hand, said he's going out of state. It's full tuition, and guess what? As you grow in income, you didn't do your savings, just like what I quoted in the Bible. It will come to that time when you may have that income, but you don't have the savings. And then when they plug in your FAFSA, you don't qualify for Pell Grant. You don't have savings. So what do? You may have to force that child to take a loan. My son said he's not filling out the FAFSA form because daddy and mommy promised him they will pay for his school fees, a tuition without any loans. We had to pay $30,000 for UNCG, full year, last year, because he didn't have scholarship, and boys, unlike girls, unfortunately, don't take very good time in terms of applying for scholarships and different things. You have to really push them. You know, he can spend his time on video games and all that. But I have a wife who is very good at savings. She's passionate about savings. She's passionate about debt. She will scream at you about going into debt, about this thing. So thankfully to her, we have done some savings that help us towards that education. you know. But there's a lot of couples, and that creates a lot of conflict in homes. Because a lot of people who do not have those financial things like that have a lot of struggles. What about me? Even as a financial person, I have my own struggles. I've made financial mistakes too. I don't know who knows, how many of you know Dave Ramsey here? He's one of the biggest names in talking about advising people, but he talked about it from a place where he had filed bankruptcy, made mistakes. That's why he hates debt. So, to build a solid rock, please avoid debt, save, save, save. I can't emphasize that enough. Now, if you're in debt, have at least 2 to 3 year plan. You know, consolidate, do what you call a financial needs analysis. List out all your debts from the least to the highest. Plan on paying them. If you have to do extra job, do extra job. Seek knowledge. Seek for ways that you can earn extra to pay off those debts first. Because without paying off your debt, it will be like something you are dragging along everywhere you are going. It will be hanging on you. And then when we talk about even helping someone else, it could be your siblings or somebody ask you for $100. Even in church, if my brother comes up and talks about giving, and you start frowning because debt, this thing. So there are ways of doing these things. There are tax strategies. There are investments. One of it is insurance. One of it is 529 accounts for your kids. But I've talked about the 10% rule. So do your 10% rule, and later you can increase it. Work towards paying off your debt. Now, to avoid health crisis, give yourself a period of time, 2 to 3 years or 18 months or thereabout. Consolidate your debts. And then let your money now work for you, not only your hours that you put in. You know, seek other things. That's where the things like insurance. Insurance can also be an avenue where you can save money. There's what we call $1 million baby. For those who have little kids now, please seek advice on things. You know, we are available. We can show you different strategies that we can use to grow your money. And we can tell you how money works. There's a rule of 72. Simply state it's how money can double within, if I divide 72 by 6 or by 1, it's 72. So if you're investing 1,000, it will double every 72 years. If you divide it by 6, what do you get? 9. It means if you have a savings at 6%, it will double every number of years like that. So there are different rules of how money works and different ways of investing and all that. And I'll be glad to talk about it more. Thank you.
Thank you so much. You know, one thing we all have here in our community is miracle. Miracle, no tire Jesus. If you are good, bad things can happen to you. If you are bad things can happen to you. I like the way it all happened, Dick and Sonny, with the L talk coming first. So the thing about it is, you could be using life insurance to transfer the risk. When you are insuring yourself, you are all about. Thank you. So when you are insuring yourself, you are just doing the risk transfer. Transfer those health challenges, all those things you could face down the line. Transfer it to the insurance companies. Instead of using your children to be your backup plan to pay your bills when you are 65, when you are 70, if you do a policy for yourself that has a living benefit, if it happens, if you are diagnosed with cancer, you get a portion of that same money, that life insurance that you have, could pay that medical bills. You could imagine falling sick and having $1 million policy, and you diagnosed with cancer, and you get paid $500,000 to treat yourself. The sickness is 50% down because you've transferred the risk. But most times we are short-term. We always have short-term vision, like, that thing is not growing. You need to know what you are planning. You are not planning for 1 year, 2 years. Insurance is meant to do during your accumulation stage to be accumulating wealth for you. If you have living benefit for yourself, you are protecting your investments with permanent life insurance, and you could be using a term with living benefits to guide you. So that down the years you want to distribute anything, you could take money out of your life insurance policy. Because we all need to be doing this. We need to be planning the legacy for our kids. We need to be planning, having long-term care in mind. Most times, 65 to 75 is when you feel the brunt of the mistakes you make in your early years. We'll be outside, like my brother also said, we'll be outside to show you strategies that you could use. From day 15 to infinity, you could use your life insurance to protect yourself, to gather wealth. You know, you will remember your great-great-grandfather if he left a wealth for you. If he transfer $1 million to you, you will remember his name. That's how we remember the Rockefellers. That's how we remember everything. People use life insurance to kickstart their business, to kickstart their family wealth. Let's all leave a legacy for our kids. Thank you.
I really want to apologize that they have so much stuff to share. And that's going to be outside, the table will be there, but we have to honor our guest speakers who have stayed with us for over, for a long time now. Their time is precious. That's why we have to make this short. But please, 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 like I said, there is no transformation without revelation, and there is no revelation without knowledge and information. There's so many information that has been passed to us. There's so many knowledge that has been shared. But knowledge is useless until you apply it. So everything we hear today, both from our pharmacists, both from our Dr. Ajayi, who's talking about having a primary care doctor, both from Dr. Kuzikabi, Dr. Fitzpatrick, the financial team, it's going to be useless if you just go home and you forget all about them. And so right now what we're going to do, because we know people are waiting for food, it's outside there, it's fun time, we want to take a time to appreciate Dr. Kuzikabi and Dr. Fitzpatrick, and I'm going to call my elder as we do a little presentation to them. You can come, sir. Once again, I think when we're planning, this is a program we do every 2 years, and it's organized by you can see us wearing, we are Gospel Faith Mission Church, but we have a team there that is called S.W.A.T, and we are called So Winning Ardent Team. We are people that are passionate not just about going to heaven, but living a life that Jesus died to give to us, abundant life. A man is made of 3 parts. Their body, which is the casket that holds their spirit and their soul. If our body fails, our spirit departs. And for our body not to fail, we have to take care of it. And that is this essence. When we were thinking about it, we met and we discussed. And I was going one morning, and I just saw Dr. Fitzpatrick because he come early to work, like before 7. And I ran behind him. I'm like, doctor. He's like, okay, what is the drug? I said, can you come and speak at our community fair? It's okay, come to my office, let me think about it. And today he's here, assemble, not charging us anything, willing to accept it. So on behalf of my team, on behalf of my pastor, on behalf of Pastor Taiwo Fagui, who could not be here, he's our national overseer for the whole government all over the United States. And now our board of elder and the government, we have a token that our elder will be presented to Dr. Fitzpatrick, and it came with a plaque. You can take it out. Dr. Fitzpatrick, please. And then we're good. The SWAT team will take picture with you so that we have our record. Yes.
Doctor, thank you so much for coming, for honoring us, and also for impacting us in a very powerful way. Thank you for your service, your humanity. On behalf of my pastor, Pastor Taiwo Fagbui, the national overseer and the senior pastor of this church, I want to let you know that we appreciate you and we thank you so much for coming. So this plaque says, Government House of Change, appreciation for Lawrence Fitzpatrick, MD, for your outstanding presentation at the 2024 S.W.A.T Community Health Fair and Outreach Program. Thank you so much for your time and effort. Doctor, we appreciate you.
Thank you. It is very impressive that you guys are doing this for each other. I'm really impressed. I think Alan probably is too. So thank you for the opportunity to be here.
Thank you.
I want all the SWAT to come and take picture with Dr. Fitzpatrick. Doctor,
Can we do
and then we'll do that later.
No, can we do the one for Dr. Allen first, then we can now do it together.
I want
Let's
to
do
do
the
that.
presentation for
Okay.
Dr.
Oh, okay. All right, let's do the presentation for Dr. Allen first, and then, okay. Sorry.
Can we take this out, right?
Yeah. Oh, before he says, I just want to say something quickly. So, Dr. Fitzpatrick, and Dr. Kusikabi, like I said, he works like on my floor. He's just always smiling. It's easy to talk to, so I kind of like bond with him. And so when we're going to do this, I'm like, we have an event coming up, and I think prostate cancer is something that I need my community to get aware of. And like, okay, let me check my schedule. And then he went for vacation for a period, and I was just calling him. He gave me his personal number to be texting him and calling him. So thank you so much for making time for us.
Dr. Allen, once again, thank you so much for coming and also for sharing your wealth of knowledge. How many of us were blessed? Amen. You know, Deaconess Sonny did mention that there is no transformation without what? Revelation. So revelation is not only, from the Bible, right? So there are also, health revelations, also things you don't know before. God opening our eyes, to so many things. So we really want to appreciate you for your commitment. Thank you for sharing your wealth of knowledge. We know very well your tight schedule, but yet you are still able to make it here. So on behalf of my pastor, Pastor Taiwo Fagbui, the National Overseer of the Gospel Faith Mission International and the Senior Pastor of this church, we want to let you know that we appreciate you. And both yourself and Dr. Lawrence, you're welcome to fellowship with us anytime. Amen. Please step forward. Thank you.
As Dr. Fitzpatrick said, thank you so much for inviting us, and it's wonderful to see so many people out in the audience taking an active role in your own health, making sure that you're getting the information that's going to be very important in keeping your own bodies very healthy and in good care. So thank you.
So we want all the SWAT team and the board and all the board and leaders to please come and take picture with Dr. Fitzpatrick and Dr. Kusikabi before they leave. All the SWAT team, please come. We are the organizer of this program, and if you are part of the board or deaconesses, elders, please come out and take picture with them. Doctor, come to the middle. Let them be there. Come here, sir. Okay, it needs to be. Come here, sir. And the others beside them. Yeah, in the center. Yeah, both of you. Yeah, both of you should be at the center. Either. Okay, if you are a SWAT member, come up, and then we're going to take that picture. Do we get somebody to take us the picture? Okay, thank you. Everybody, please, you can step up. Make sure they can see your face.